Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Today I'm talking to Paul Loos and Dennis Jarema. Along with Sean Keenan, they started the Prolonged Field Care Working Group. Today, Paul and Dennis are going to be talking about the Austere Critical Care Master's Program they're enrolled in, as well as their concepts and future thoughts on the prolonged field care.
Hey, I'm Paul Loos. I've been doing some prolonged field care now for the last 7 or 8 years, coming up on 9 years, I think. I've been in a couple of different operational units. I started my career as a combat medic in 2003 with several deployments to combat zones and then several other deployments as well.
I'm Dennis Jarema, another 18 Delta, just like Paul. I started off in the infantry, strange enough, with 10th Mountain, and then I moved over to Special Forces, and I've also got several deployments.
I'm going to ask you some questions about prolonged field care, how it started, and where it's going, and what your future goals are for it. But I first wanted to ask you about your experiences in the Masters of Austere Critical Care program that you're doing with the college.
Okay, yeah, so I appreciate it. I was originally looking for a program similar to this or similar to the field of my interest because I didn't want to just go to a school to get a random degree. I wanted to actually learn something in the field of my interest, stuff that I was already doing. But unfortunately, given my time out of operational medicine and even instructing and now administrative stuff, like I don't get to see patients every day, so I thought it important to actually get exposed to go into some deeper medicine and also sustain the skills and knowledge I already had. So instead of going to get a degree in emergency management, let's say, that I didn't plan on using, something like this that could further my knowledge and skills and reinforce what I already knew would be more valuable to me. I had a plethora of joint service transcript recommended credits, and then also I think I've been to 4 or 5 community colleges and technical institutes here in the States, and just never ended up with a degree due to deployment requirements and other things that happened. So I was looking for something that would fill that gap at a higher level and take what I already knew and what I already had and put that to good use.
Yeah, and why I enrolled is, I had already got my RN, my associates, and got my nursing license, but just continuing to search for anything that will further my medical ability also got me farther away from operational type medicine, and that's kind of the nature of the beast. So when this popped up, this opportunity happened, I jumped on it because it's specific to things that I care about, which is austere medicine, austere critical care. And not only am I going to be able to up my own game, but I can also pass that information along to my brethren so that they can also up their game.
Thanks for that. And what do you guys plan to do with this degree program?
I plan on probably continuing what I've been doing as far as training, combat medics. But there's also several other opportunities constantly as far as going overseas or different contract work. And just having a degree like this, it opens things wide even farther to be able to go even more austere and some pretty adventurous places.
Yeah, I would say right now it seems like in that world that Dennis is talking about, the baseline requirement is to be an NREMTP, and most of us in SOF now are going that direction. We're getting our NREMT paramedics, but not very many of us are actually utilizing that. And so one big weakness we see is the lack of experience in the ACLS and the higher level critical care, and this definitely gives you that opportunity to learn more on that side of things, and then not being a credentialed clinician, you're a certified paramedic if at that point. It really depends on who you're working for and the scope of practice that they're going to allow. But if you don't have the knowledge or the skills, they're definitely not going to allow it.
Do either of you guys have an inkling of teaching in academia in the future?
Yeah, I mean, I would say that we do teach in academia as far as the military is concerned. Our students are probably their knuckles go a little closer to the ground than maybe most, but yeah, absolutely and I think it's necessary, as disasters, whether natural or man-made happen, civilian medical systems find themselves in very austere conditions, and they don't necessarily have the experience of how to deal with that. So I think having people capable of working in that type of environment just improves care all the way around.
Yeah, I would say for me specifically, like I've gotten to do that quite a bit over the past 5 years or so, traveling all over the world, teaching doctors, PAs, nurses who usually work in hospitals how to kind of transition to work outside of a hospital with limited resources. So I've been pretty lucky as far as that's concerned. So this is just another avenue to be able to do that.
I want to change pace a bit, lads, because I mean the elephant in the room is the what you two have done in the past. With can you talk about the start of the PFC working group? How did that get off the ground, and how are you guys? How did you guys get to where you are now?
Yeah, that's a great question. If we go all the way back to 2013, there was a group in NATO talking about the same thing as far as extended care or prolonged field care. Here in the U.S., we were also looking at the same issue because the global war on terrorism was still going strong, but there are many other deployments that our guys go on where there's not a doctor or nurse or any other higher clinician available. So we were still stuck with A, prepping for combat, but also B, prepping for everything else. And that included doing austere medicine without any kind of backstop all over the world. So 2013, NATO got together and they said, we're going to call this prolonged field care. We had the Special Operations Medical Association conference there in Tampa in December of 2013. And I remember Sean and Justin both presenting topics on that subject. And then from there, I was lucky enough to be present as like a young E6 at the time, where my PA had dropped out, so there was an open slot to Soma, and they said, hey, you want to go? I was always up in the aid station for one reason or another, and I jumped on that opportunity. And so when I saw them talking about this stuff and the conference was coming to a close, everybody's getting ready to go back home, we still had obviously a lot of unanswered questions despite the presentations that they both gave. So we knew we had all these questions that were popping up, and the more we looked into it, the more questions we had. At the same time, during some of these deployments, we would end up in an austere environment where it was so austere, and the things we were doing, we would request a surgical team, and we had some great conversations with those surgical teams. But it was, two medics, and you had a surgeon and CRNA, and whoever else was there with them. And so we have these great conversations that were going unrecorded. Nobody else could get them. It was just us. So at that time, Justin and Sean and I think there were a couple others originally as well who started the podcast. So the podcast was started from those conversations we had in Africa. We wanted to kind of revisit some of those subjects and kind of do deep dives into each one of those things, whether it be telemedicine, the overall idea of prolonged field care, or other specific subjects. So we started doing the podcast soon after that SOMA conference. Well, I think my small contribution there was that I got to kind of just raise my hand and say, okay, great, this conference is coming to an end. You guys want to start a podcast, but how are we going to maintain the integrity of this group who wants to continue working together going forward? And there was no kind of social media presence at that point. So I said, hey, let's just start a website for show notes and some kind of social media, Facebook, for us to all stay in contact, because a lot of times those email chains would get unwieldy, or you would have to set up conference calls, and most people couldn't make it. So social media worked out really well, and that blew up pretty quick. On the website side of things, as I started listening to the podcasts and writing show notes for those initial first few, that's probably where I started learning the most. When you're either prepping for a podcast or you start prepping for the show notes, you're looking through the research, you're getting all the resources that the guys need. Like that really cements some of those lessons learned in your head, because you're seeing the same thing over and over and over. So for every podcast, it might be you record for an hour and a half, you edit for 5 hours, you do research for the show notes, you edit the podcast or the show notes themselves, and then you release it. And then also after that, it wasn't just getting released on the website, but it would actually get released on all the social media platforms. And so I would be constantly engaged with people asking questions, whether it was Instagram, Facebook, sometimes Twitter. And so the information was being bombarded on me from the get-go for every single one of those podcasts, and they were cumulative. So as time went on, you would still get questions from those early podcasts, and then you would get more from the additional ones. And it's a big job. So I think at some point Dennis came on, he started helping out. I got super busy with my instruction and everything I was doing at work, so Dennis ended up taking over the podcast side of things, and I still maintained the website at that point. What about you, Dennis?
Yeah, I mean, I think I came in at the probably the perfect time, because all the work was done. So it was really just, having a schedule and just organizing things. And when I took over the podcast, and just staying on target, and because of where I was working at the schoolhouse, I got to see all the questions that people had. And so that's too easy. You make a topic for a podcast to answer somebody's question.
Yeah, the one thing that I can't discount is there was a huge effort. There were over 100 people on an email, and we called ourselves a Prolonged Field Care Working Group at that time. So whenever there was an issue, this is before we had any kind of clinical practice guideline, we would go for kind of expert consensus, which counts for something when there's nothing else, because we were still actively sending teams out the door with these questions and no answer. So at that point, we said maybe an 80% answer is better than no answer, and then we can go and really dig into literature and everything after that. So we had position papers that went in on the JSOM. We had clinical practice guidelines that we started writing. We had then, lower than that, obviously, were the blog posts that we wrote. And so you were kind of doing every level of academic rigor, from none whatsoever in opinion all the way up to analyses and doing actual research, which obviously that takes a long time. So for that research to actually come to fruition, it was probably already 2017, 2018 when this thing started in 2013. So there was a lot of effort by a lot of people inside the joint trauma system, outside the joint trauma system, civilian institutions, inside the military, everybody kind of working together to get all these answers. And then I just got to be lucky enough to be the touch point and the person to disseminate those once it was something that was worth getting out there. And the last thing I'll say on that is also being exposed to all my other fellow medics is guys have some amazing ideas and solutions to problems that other people haven't even faced yet. And so what you see in SOF a lot of times are these tiny little silos everywhere, and one guy will figure out a solution to a problem, and that fixes his problem and he goes about his day. But then he'll bring it up to me, and I'll be like, oh, that's pretty interesting, because I've had 4 or 5 other people bring up similar things. So you saw the wheels getting built and rebuilt by different people all across the enterprise. And that was another thing where if I could take a cheat sheet that some guy is using and post that, somebody else doesn't have to create that cheat sheet. They can now use that brain energy and the time that they have on something else. So I think that's where that was also really valuable.
Right. And I mean, it's not just, copying and pasting other people's stuff. It's essentially like a board review over, essentially the world of medicine anyway. And, you get people's comments about, different medications or different dosings or different considerations, and it just keeps getting refined and refined and refined until you have something that works really well in a lot of different situations.
So it sounds like, I mean, I've seen a profound team approach to this as well, of a lot of people who have been involved with the CPG side of things, the research side of things. I came in a bit late. It was 2015, I think, that I started to see what you guys are doing. And by that time, Paul, like you said, that you had a lot of push to get more of the science behind that, evidence-based medicine behind that. So let me ask you guys this: where do you see PFC now? So where do you plan to push PFC? It's now that you have the PCC with the normal army, and the PFC is now soft only. What improvements do you see coming down the road, or what would be the golden uh, nugget that you would like to see this in 5 years? Where would you like this to be?
That's a great question. I don't know if I've ever considered like to set a goal or where we would want to be in 5 years. As crazy as that sounds, it's more of hitting the targets as they pop up. That's kind of how it's been the past few years. But with the prolonged casualty care groups, there's one doing a kind of a required curriculum, and then there's another one that does the guidelines, and they're pretty intimate with each other. They get together, they still talk about obviously the guidelines are going to impact the curriculum, but Jamie Riesberg and Mike Remley did an amazing job on that. I got to add a little bit of my 2 cents, but there was a whole nother group of people that we then reached out to at that point, because we did want to reach out to the rest of the conventional force, because my time in the conventional Army as a medic was long gone. So we wanted to make sure that the Navy, the Air Force, everybody else was represented as well. So it made it a little more challenging, and I think what they ended up coming out with is a great product in that the overall CPG. That's the prolonged casualty care CPG. So what I think is going to happen going forward is that will get more robust as the prolonged field care clinical practice guidelines actually sundown. I mean, if you look, I think the burn one was written in 2016, so now that's already 6 years old. So as they update the burn care recommendations, they'll just update them on the PCC guidelines and then probably end up deleting the old PFC guidelines. And the interesting thing about all these guidelines is you have to write that for the E2 combat medic that's maybe in a conventional unit deployed somewhere, or that goes all the way up to the tier 4, where you get past soft medics and you have a PA and a battalion surgeon in an aid station with a bunch of medics. So it was really a task to try to hit all those demographics and make sure that it made sense for all those people. And again, they're just guidelines. It's just something for some people to start with. But you can imagine if you just came out of IPAP, or let's say you're a GMO there in the Navy, you haven't even gone through your residency, and they say, okay, you're in charge of the people on the ship. What does that mean to you? And how do you even start preparing for that? This is a great way to at least get a jump on it. And then if you're, let's say you're well versed in one area but not another, you could then focus your efforts preparing yourself and training yourself with those guidelines in the areas that you're weaker at.
Yeah, where I would like to see prolonged field care, in 5 years. I mean, I'm already kind of blown away about how much we've actually moved. I mean, we've essentially, I think, turned the Titanic, 90 degrees. But, there's still, what I like about what's happened, I guess, is I've seen the kind of the cadre of the caliber of the medics, definitely like ballooning out. It's not just tourniquets and chest seals and needle Ds. Now they're pushing blood. They're using more sophisticated medications. They're thinking longer term, because that was actually a reality. In GWAT, you'd have a patient off the ground in 15, 20 minutes, and we never really had to deal with, longer casualty care. And so we had a bunch of, the thought process is essentially just those short interventions, get them on the bird and move about your day. Now it's not the case. So just kind of opening people's aperture as far as what is going to be required for this mission set. And, I see the medics, rising to the occasion, asking better questions, asking more in-depth things, and I would like to continue moving in that direction. Not just with guidelines and uh, podcasts, but we also got to think about even the small things, the small details that add up to big things. So I'd also like to push into more video type demonstrations and how-to type stuff myself.
Yeah, on that with the video stuff, the Committee on Tactical Combat Casualty Care has done a great job with all the TCCC stuff. So when you get into the baseline medical knowledge, there is a plethora now of videos, guidelines. They have the curriculum pretty much written out up to Combat Lifesaver, I believe, at this point. So as that expands, and guys are getting to the point where they're proficient, because you shouldn't just jump right into prolonged field care. You have to make this common disclaimer. Get good at TCCC and get good at clinical medicine, and then you can start tackling what happens next, because you don't want to start looking at crush and burn injuries long term before you know how to treat them short term, or just put on tourniquets and junctional tourniquets. So what I do notice is that if somebody is weak at TCCC or even just normal clinical medicine, that if you put them in a prolonged field care situation, what I notice personally, this is my own opinion, is that they then notice their own weaknesses, because they then have to deal with their own inaction or the wrong action. If they don't get a tourniquet on in time and you build the scenario correctly, then that forces them to deal with their own consequences. And so I think that's a great way for guys to learn. Whereas if you just train a 10, 20-minute scenario, they don't get the tourniquet on, they don't get blood on, they hand the patient over, those consequences are lost on them, because they would be put on the next level of care as opposed to dealing with them themselves. So I think it's a good way to open people's eyes in one form or fashion, but it's also a great way to teach.
It is a valid point. I mean, Sean Keenan always says, you don't have PFC without TCCC. And deploymentmedicine.com is doing really good with the videos. Do you see prolonged field care having something similar as far as website videos and education that you see on deployedmedicine.com?
Yeah, I think I should probably address that. So the prolonged casualty care, I think, is going to end up being, don't quote me on this, but I think it'll end up being a sub-working group of COTC. And so there will be a group of people who specifically work on that, the PCC guidelines, but under COTC and under the joint trauma system. And then I think where Dennis is going to fall, and he can correct me if I'm wrong, is we'll still focus on soft efforts and the R&D of some of these TTPs, and maybe not equipment, but at least the research, the questions, and how our guys are doing this stuff around the world. Because as I said before, if you have medics deploying to 70 plus countries every day, all day, we learn a lot of lessons. We just have to collect them and then disseminate them appropriately. What do you think, Dennis?
Yeah, it's again like we're just trying to, I guess, for the PFC specifically, our target is the special operations, but everything feeds kind of into everything else. So lessons learned from us always move over to more conventional forces. But yeah, absolutely. I think we really need to, show people how to do things. And once you show them how, as an example, like, I don't know, different ways to get an IV access on somebody who's hypovolemic, like that's a pretty tough trick when you're just used to practicing on healthy people. But if you kind of arm people with kind of a pace plan of how to do this, they're going to be much better prepared. So I would like to kind of push into videos like that, just showing alternative ways to get the job done.
That's it's quite an undertaking to be able to start divvying up all the tasks found within PFC to get people, actors, to start making these videos. But we have a template. The deployedmedicine.com has professional level videos and PowerPoint slides, some of them in Ukrainian now for the conflict, as well as downloadable PDFs. And it's something that I think the PFC working group can emulate for the SOF prolonged field care guidelines. Maybe it's pretentious, but um, I I think that would be a good direction in the next 5 years.
Yeah, from what I've noticed on our on the website when we were really active is that those PDFs and cheat sheets and things were by and far the most downloaded things, the most visited pages of that website that there were. So yeah, you're right. I mean, guys are always looking for these resources. When you have limited time to prepare and somebody else has done that work for you, that's a huge help.
That's definitely something we can talk about for the next 5 years and moving us forward. You guys have put a profound momentum in place with PFC, and
Appreciate it.
I
Yeah,
would
thank
like
you.
to see that momentum continue on and be you guys be the leaders in this soft level prolonged field care. It's pretty amazing to see what you guys have done. So, any last comments you guys will have? I kind of want the absolute open blank slate comments that you guys have about the college or about any of your experiences or anything you would like the listeners to know.
I've got two that pop into my head right away when you ask that. So the first one was during 702, we had a bunch of videos, and they were everything from presentations on, let's say, burn care from Dr. DeMello up to you had actual case studies presented from KCMC. And those were invaluable. So if you've never, like, for what I was talking about before, if you've never just taken a podcast and had the idea to write down show notes, it was very similar to what we had to do for those videos as far as writing out the Gibbs review. While maybe some of it was a little repetitive, the questions that they asked, the overall feeling was the same, where you're listening to the speaker, you're interacting with them if you could log on at the same time, although you didn't have to, so that was convenient. But then you would have to go back, probably listen to it again maybe, but then write down your thoughts and then what you would do with it in the future. So that was actually pretty valuable. Um, but to me, the most value I got out of 702 are those case studies. I mean, when you're talking about a patient who I think one of them fell off of a road, severed his spine, and then was something like 200 kilometers from the clinic where they needed care. So they sent a motorcycle team to go pick this guy up who had a severed spine, a pretty severe back injury, put him on the motorcycle with somebody driving, and then sandwiched him between that and another caregiver and drove the 200 kilometers back to the critical care facility. That was mind-blowing to hear stuff like that. So the stuff that those guys deal with every day, I mean, they're running vents with no ABGs, with no capnography, and the guidelines that they've kind of been doing for themselves those are mind-blowing. So those are one of the most valuable things that I got out of the whole experience.
Yeah, it's just kind of the breadth of experience that you get out of it. Not only the instructors or presenters, but also you have the students, and they're from all over the world, and how they deal with a situation, um, is drastically different than what we may do in our tiny little bubble, and it's good to kind of open things up and see how other people kind of tackle this job and learn from that experience.
Yeah, that's a great point. I mean, even the differences between the paramedics in Canada, let's say, um, versus somebody who's contracting in a war zone or a conflict zone. I mean, some of them resemble what we do, and then some of them are so completely different. Where yeah, you definitely can gain some pearls from the other students interacting. I think the last thing that I would add to this whole thing, maybe I was thinking about it some more, like where would I like to see this going, is that I think we've done a pretty good job of kind of disseminating information on what to do and kind of how to do it. But I think at this point in my career, facing down the end of my Army career in the next year or so, like how do you prepare other people, not just to do it, but to teach it? So I've really been trying to focus on how do you instruct other people to instruct these subjects, these very complex topics that maybe they haven't had the chance to put in the hundreds or thousands of hours of study. But I think we're getting to the point where there are some pretty um, solid guidelines that we can have them go off of. We just have to show them a little bit more. So now when I teach medics, I say, hey, this is not just for you, but when you are teaching this, this is a good way to do it. So I try to preface most of what I teach in that sense, and I think that gets another level of buy-in from them, because then they quickly remember, like, oh yeah, it's not my job just to do this, but it's my job to teach my own teammates and my partner force whenever I deploy around the world. So that's a great opportunity to spread the knowledge.
It's a valid point within the military as well, NGO. You need to train the people around you because if you're the only medic, they're the ones that be working on you if you go down. But more importantly, teaching people how to teach. And that, I remember on the ODAs, I mean, we go to JSETs and this is what we do, that we teach. But I don't remember once where we went into a country and taught them how to teach so when we leave, they continue on with that teaching. So Paul, you're absolutely right. Teaching someone to teach is a challenge. The instructor development courses, there's tons of them out there, but there's a lot of really good medics that wash out. And within the college, I get MD PhDs who come in and say, I want to teach, and you put them in front of the class, and you're like, no. So how do you teach someone to teach is a challenge.
Yeah. Yeah, absolutely. I think they got to have the desire has to be there for sure, but then you need some experience. I mean, you can't get good at teaching without teaching, again, just like medicine. So you got to get up there and do it, but then you really have to relate to your audience, and you're definitely gonna stumble, you're gonna fail, you're gonna learn, and you just have to do it. And I think at this point I've had a lot of opportunities to go and do that, and just reframing the way that I teach as far as, okay, if you're teaching this, this is how you're going to do it, or I suggest this has worked for me. Being able to share those little bits and pearls has been really valuable to my students.
Yeah, I mean, obviously you need experience to just be called to the game, but I think where I see a lot of instructors fail, especially initially, is they don't leave their ego at the door, and they spend more time trying to convince the students that they know what they're talking about,
Hmm.
and they kind of lose focus on it's the entire point of this class or course or whatever is it's the student, to bring the student up. So um, if there was one piece of advice I could give to anybody looking to teach, is like just that reassurance, like you've made it. You've been asked to teach because people already know that you have something to provide. Um, just convey that information to the students, and it's okay that they have questions, because if they already knew it, they wouldn't be in the class. So just kind of have that humility and maybe some empathy as well for the students, and I think things go a lot smoother.
Yeah, another thing that comes to mind when we're talking about this is I remember having a JSET maybe back in 2012, a joint combined training exercise with a partner force where they had been taught TCCC 12 times by prior units. So then I get there, and my plan is to teach them TCCC, not knowing that. And I do a quick assessment, and oh man, these guys are actually really proficient. What do I do now? Like, what do I teach next? And I think if we're talking about prolonged care and they've already mastered that TCCC, they've done it a couple times a year with different teams over and over and over, I think you have to elevate their game as well. And so that's kind of what my focus has been on, is arming those medics with those the teaching pearls so that they can then go into these other countries and teach their partner forces that stuff.
Yeah, it's just the key to just kind of plant that spark, um, to ask the students those questions that make them curious and want to expand their knowledge. As long as you provide a framework that they can stay within, um, even when you leave, they're just going to continue growing.
That is the desire of all instructors, isn't it, for them to continue to grow and possibly even surpass you as in their knowledge, and teach them how to learn and how to be better. I think one of the biggest lessons I have to give to my faculty who come in and teach is the humility, and not going in and saying, I'm God's greatest gift to this, or I'm a knuckle dragger, I've done this, and be able to say, I don't know. So if and it happens all the time. I teach docs and they're smarter than me. They're more educated than me, and that's fine. And having them ask questions, and like, I don't know, but I'll get back to you. And I learn from that as well.
Yep. When you get a really strong student that has like memorized the guideline that I haven't looked at in a few years, and they're asking questions about it, I'm like, oh, I better get back and look at that one again. But it's great. It's great to be challenged, especially on the stuff that we already put out. It's hard to stay abreast of everything in medicine all at once.
Yeah. But I mean, even you say you get that guy who's memorized everything. Well, then, I mean, the next question is, all right, well, go do it. And then you find other holes, because you always have everybody that's across the spectrum. You have the guys that are, maybe they aren't very advanced in their knowledge, but they're very good at doing the basics very well. And you have the other end of the spectrum where you have somebody who's memorized all the guidelines, all the books, they know all the answers on a written test, but when you ask them to do it in actuality, then you start to find holes. So everybody has something to learn. And sometimes it's just learning that you need to shore up your base a little bit harder. Still allows that person to expand. It's medicine. It's the art of medicine. So it's not just memorizing facts and figures to put it into a machine. Like, you actually have to do the thing. And sometimes the patient doesn't react the way you thought it was going to happen. So what do you do next?
Yeah, great point.
Yeah, I see this as like head knowledge and hand knowledge. And you're right. So there's going to be somebody in the classroom that knows more about the critical care textbook than we do, and they can start quoting research studies. But can they do a BVM? Do they have the hand knowledge to back up the and on the other hand, you have somebody, well, I can do femoral lines. Great. Tell me the science behind it. Oh, yeah, you need both.
Right. Yep, absolutely. And it's okay to have a hole in your knowledge. It's not okay to let it sit there.
Agreed.
Yeah.
Well, lads, I appreciate your time. I know that you guys have to get back into the classroom there at Bragg, but I appreciate your time, and I look forward to seeing you guys complete your Masters of Austere Critical Care and continue to thrive. You are impressing me as you go through the program. It's an honor to have you there.
Oh, I appreciate it, Albert, especially for the opportunity to be a part of this cohort.
Yeah, no, thanks to you and all the faculty, Dr. DeMello and Diosei and everybody else. They're great.
All right, lads, appreciate it. I know you got to get back. We have 9 minutes to get back to the classroom. Sorry about that. Good crack, as we say in Ireland. Paul Loos, Dennis Jarema, thank you for joining me today on the podcast, and I look forward to seeing what you can do on the Masters of Austere Critical Care. That is it for this podcast, and we will see you next week. This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, C-O-R-O-M, corum.org.